Hey, everybody, it's Kevin and Dan and Jaron, all here to tell you a little bit about some exciting things happening in pharmacy. They're innovative. I've been flying by the seat of my pants all day today. The Walker household has been really busy, and it seems like Dan and Jaron are always one step ahead of me in clinical innovation. So I'm looking forward to catching up and hearing about all the amazing things that both of them are doing. So I'm going to switch it over, play the reel really quick, and we'll jump right back into the conversation. Look forward to you guys joining us. Once again, thank you, Dan, so much for joining us here. And Jaron, I'm going to pass the mic off to you to give the intros.
Yes, thank you very much, Kevin. I am just thrilled to have Dan Buffington on the show. I met him at the Florida ASCP conference about 3 years ago, I want to say. And he was presenting in a course I was taking about innovation. And I was thrilled to see that he was a pharmacist and that he was running his own clinic. And that is just a huge deal to me, and I hope it is for everyone else. So I view him as a mentor and a valuable asset to our profession. He does a lot of amazing things with APHA as well as with the American Medical Association. And I'm thrilled to have him here because this topic is something that's very near and dear to my heart. It's something that we have not really established the way we've had opportunities to do so. And you are one of the very few people that has a very unique and helpful perspective on it, and talking about market value of a pharmacist performing services. Thanks for joining us today, Dan.
Thanks. Appreciate the invite. And I kind of think when you use the term mentor, it just means I'm the older one in the crowd here. So, but with that, with age and time and experience comes successes, learning curves, and an opportunity, as Jaron really pointed out, to find where, and I see this in your prior podcasts, Jaron, we've done and worked on projects together over the last couple of years. As a benefit of having met at previous meetings. We do share the concern and the need to raise the bar of the profession, and that's both clinical practice activities. It does not mean divorce from product. It means find a way to thrive and survive with the delivery of clinical services in addition to product management and product innovation. So with that, what I think we share is that there's been years worth of saying what is needed, what do we have to build, what is already built for us that we don't know, and through that has come a wide range of aha moments where we've had to say what are we missing to help facilitate. Kevin, I saw in a prior podcast you had spoke very eloquently to how many students in many academic programs across the country train people to see and pursue opportunities that fall into a narrow set of diverse boxes. And we'll just call those traditional pharmacy practice settings. So one of the things that's happened over the years is those settings have become more diversified. There's new and innovative practice roles, not just product focus, but clinical practice roles, public health roles, clinical research roles, opportunities where others have seen the depth of clinical training and the diversity of understanding of pharmacology and its applications. So not just the product, but how best to improve health outcomes and improve patient safety. And with that comes the challenge, and in a minute I'll be glad to share kind of the path that I've taken. But what it challenges us is if you're going to offer that service, if you're going to develop something innovative, if you can't figure out its value, and if you can't figure out how to market and develop that and make it sustainable, then it's just a great idea. And Amen. Great ideas have to transition into something that becomes alive and thriving. And at a key piece, and so I don't think any of us should shy away from the discussion, is that healthcare is a unique type of business sector. And I think that the prototype is that if you say, well, physicians get it, and many other allied health meaning those of us who are non-MDDO, and quite frankly, that makes up a tremendous portion of healthcare providers. If you say physicians get it, I will challenge you that having taught in a medical school, nursing school, and pharmacy school for the entirety of my career, that is not a safe assumption. A lot of healthcare entities, medical practices, clinics, health systems, ACOs, medical homes, the new and innovative models that go from prior fee-for-service to value-based, all of those provide and wrap around physicians an administrative layer. We, I think, just have, as a profession, as a sector, probably not properly looked to how to mirror what medicine does in that side, the business, the how to maintain and keep a practice and service viable. And yet at the same time, what I will say is that my entire career, post PharmD residency fellowship, was to find an ideal medical practice model that fits what we do, not primary care. Yet when you put a pharmacist into a primary care setting, health outcomes improve, patient safety improves. That's where to place a pharmacist. We work well in any setting. We make positive impacts clinically and financially in every setting. But what I strive to do was to say, how do I take a medical practice model? And I opted for a medical specialty practice model. So an individual who primary care patients may seek out, health plans may identify as someone who brings a unique niche set of healthcare information, packages that in the service, and augments the rest of healthcare and patient management. And I've just found that I could answer for the rest of the podcast. Everything answer is that which a physician does. So whatever you ask me has worked or not worked, I can tell you that I have, but for the benefit of working side by side with physicians in a medical university setting, but also in a very large community across Tampa, have found a tremendous amount of collegial support from physicians and their staff. And I'm going to tell you, I've learned as much from the medical billing staff to the insurance staff to medical documentation, you name it. All of those practice settings and their related support staff have helped us to shape and build a practice model. Jaron, you've had the opportunity to visit, and if all goes well, we're going to host you again next week. And what you see when you come to our practice is you walk in. Yes, I have a pharmacy license, pharmacist, and we have a pharmacy license. But when you come in, it looks, feels, and functions just like a medical practice. Matter of fact, patients will come in and say, I thought I was coming to a pharmacy. And we're very proud to say you did. And we are pharmacists. Now let's get on to helping you improve your medication list, help educate you on your medications, do the traditional assessment and monitoring, and all the rest that goes with that, whether it's pharmacogenomics or whether it's laboratory and therapeutic drug monitoring, all those pieces that we have built into the practice. So in that, everything from how to build the practice, how to develop staff, the sectors of staff that we need within our model to help us do the services, but be able to support the documentation, to support the billing, the interface and contracting with payers, clinical research activities, the diversity. So we're there to assist a patient, but we also said, if it's not the product, what is the rest of the spectrum that's going to bring value to our local community? And with that, I'm saying and totally acknowledge this doesn't have to be separate and apart from a traditional pharmacy setting. In fact, one of the things we felt compelled to do, and this goes back to 91, was to build this and demonstrate that it can be financially viable, that it can function, that it can grow and evolve, that it can be innovative on its own without product. So the last 10 years have been trying to help pharmacy practitioners of a wide variety of practice settings take those principles, whether it's how we code a service, whether it's how we document that service, how we deliver it, how we develop referral lines, and take all those pieces and start to overlay that back over different traditional pharmacy practice models. A piece I never even thought we would spend as much time on is medication access. So I approach this very much with, and Kevin, as you pointed out, and I guess the title for today's session is the value of a clinical service, and thought it just had to be absolutely a clinic-based intervention. And to a great extent, many of our patients are coming for drug metabolism issues or medication access, so navigating prior authorization programs, dealing with 340B, applying for disability programs, other types of indigent care programs across the community. So really helping people who just can't get the medications they need and finding a way to even make that service fundable to the point that you can keep it viable and surviving. So we could go a lot of different directions today in terms of questions. So that gives you an insight, is that we have a practice setting that started off trying to say, what is everything non-product, and can we build a practice and a service model around it? I can say we've done it. I can say it thrives well. I could say almost everything that we've done, whether it's I'm finishing a presentation that we'll be doing in a couple of weeks here that's on advanced practice models. That one is a deep dive to say, well, is it a pharmacist working for a doctor's office? Is it a doctor working for a pharmacy practice? Is it a blended practice, an interdisciplinary model? So it's challenging to say, think outside the box, think outside the traditional pharmacy boxes, and then say, what do you have to put in place to be able to make that financially and longstanding viable?
Can we start there, Dan? I think that's a really good spot, is defining the box. Like you have the experience to see like how the box has changed over time and how you've evolved that so it looks in a different way. And I guess for the audience to hear, I remember one of the epiphany moments in my career, Dan, was when I was doing some of my rotations even before my residency. And one of them was at a family medicine residency clinic. And so I was sitting right next to the principal MD, and all of the students would come through, or the residents would come through, and they would talk to both of us about the clinical decisions and then how to upbill something or change the billing CPT codes related to what they were doing. And I thought, this is so much different than what we do in pharmacy school. And I feel like I am missing something significant by not, like, I was thankful to have that experience, to know that this is how they do it and they understand the practice of medicine and the billing elements. But anyway, to get back to like the very beginning for you, Dan, because I think you have a fantastic perspective. Can you define how the box of pharmacy payment, how it was and how that's evolved, and then how you've moved outside of it a little bit for the audience?
Sure. So when I started this process, and I'm not alone, there's a lot of us around the country who have been arms locked and meeting multiple times a year and identifying where our gaps are and the shortcomings that we have to work on. In the beginning, it was the problem. So even when I went to school, there was product reimbursement, and pharmacists didn't have a voice or a presence in the medical reimbursement coding model. So what we would do, I mean, I can distinctly remember specific faculty, specific hospitals and services that were done this way. They would have tiered billing for the product. And if it was a product that had, say, a pharmacokinetic service, or it had a TPN service, or it had some oncology service where there was then the code for the product to bill for the product was elevated, and that made for the finances that would support the clinical staff who was providing the service. That was extremely cumbersome. And what we found is that the CPT, which stands for current procedural terminology, so there is literally a industry backbone code set for all of healthcare. What we found in the early 2000s was some of us had decided, somewhat with a high degree of energy and creativity, we would just go make our own code set, and we'll walk it into payers and hand it to them and slap it on the desk and say, here's what we'll use. We found out very quickly that doesn't work anywhere. In fact, there were many other allied healthcare professions, psychologists, chiropractors, nurse practitioners, social workers, speech pathology, audiology. You see what's happening? I'm not even close to being done. That list is very long, most of which preceded us with the same equation, same exercise, and trying to fill a gap of saying, where do we get codes and how can we find codes that are in the code set? I want to give credit to a gentleman at the AMA. His name's Michael Beebe. Michael's no longer with them. He's now a consultant to this process and is just a valued resource in healthcare billing. Michael was head of CPT at the time when pharmacy, we invited him to come give us an introduction as to how does this world of medical billing work and how did the AMA become, quote, the keeper of the code set. And it's interesting, CMS told AMA in the 60s and 70s that the diversity of coding terminology, the amounts that were being billed was a dust storm of chaos, and that they were charging the healthcare profession back and told the AMA, you must go build a standardized code set. And they did, and that's the AMA current procedural terminology code set. And it gets maintained every year there forward. And it is a very organized, very editorially retentive process that makes codes that aren't there, edits codes that need modified based on trends and patterns or needs, and sunsets codes that just aren't used anymore. With that, they also break it into codes that are used for billing, codes that are used for unique data tracking. So if a profession, a specialty needs to track something, there's a code set, category 1, category 2. Category 3 are new and emerging codes that they're fresh. Nobody knows what to do with them yet. And they're kind of putting on the training wheels and trying to use those codes. And this goes for any MD or DO or allied health. And the allied health group at the AMA CPT is called the HICPAC group, and that stands for the Allied Healthcare Practitioners. With that, there's about 25 plus specialties. In the early 2000s, we met with Michael. He gave us an explanation. We said, well, gosh, that sounds like someplace we need to be. And he looked up to the room of 30 some pharmacists and said, well, why aren't you there now? And we said, well, that's a good question. How do we get there? And he said, you apply, you meet the criteria of a licensed healthcare professional. I mean, there's a set of criteria. And he goes, I can tell you already, you meet that. And we said, well, who do we send it to? He said, to me. And he, at the AMA, they have a review process, and we got added very quickly. As a matter of fact, if you look back in AMA history, we had the fastest enter to the HICPAC and CPT process to code proposals to code proposal approvals. So what I'm saying to everybody on the podcast tonight is we've had medical billing codes for many years, 3 specific codes, 99605, 99606, and 99607. When you go to the CPT code set, it's about an 1.5 inch, 2 inch thick binder that, again, any medical office, any clinic, any lab, any hospital you go to, this code set is the location, is the place, and payers is the place that everyone goes to say, well, if you're going to bill a service, what's the code and what's its description? So Kevin, to your point, when we started this, we didn't have codes. We weren't in the coding process. So we got in, we were mentored, we did a code proposal. We have 3 codes. Gentlemen, we have a hard time getting pharmacists to use them.
Yes, that's a recurring problem.
Yeah, and to Jaron's depth of pursuit into this arena, there are, as we found, in fact, other codes across that 2 inch binder that have applicability or functionality for pharmacists as well. And I will say that probably the average pharmacy setting only scratches the surface. And we could probably do a couple-hour presentation on the title and then the difference between Medicare Part D, MTM. So the codes in the CPT code set are referred to as MTM, Medication Therapy Management. And I just want to let you know is that term does not belong to CMS. and I will say openly, and have worked for CMS. I worked for CMS for 5 years. Is they don't get it right. They got it, and they got it with the aspiration to say, let this evolve to the how we can best define it, and then disperse that application. What ended up happening is in Medicare and government programs, there's something that's sometimes a problem called benefit uniformity. And that's where a payer says, well, okay, we'll pay for this. So what is it? And then they want to be able to define it in a perfect little box that it's the same thing every time. And I will tell you is that you go through the CPT code set, that code set has evolved, and there are many things that don't work that way. Matter of fact, we now have codes that describe 30-day windows of services provided by multiple people. Hey, 5 years ago, that was a foreign concept. So even the CPT and the healthcare coding models are evolving, but our code describes 99605 is the first 15 minutes of pharmacist intervention with a new patient. A 99606 is the first 15 minutes of clinical intervention with an established patient. What's the difference? New is new, established is you've seen them before. The only caveat to that is, and folks, we don't make this up, it's everybody in healthcare has to have some assumptions and caveats. The medical billing world says if you've seen the patient in the last 3 years, they're established. If it's been 3 years or longer, you can go back and use the new patient code because you're going to have to reset up your documentation and maybe gather additional medical records. That's it. It doesn't get much harder. The 99607 is a 15-minute modifier for either one of those. So if you have a 45-minute new patient consult, 2605s, 1607. It's that simple. If you have a 30-minute follow-up, it's 1606 because it's established patient, and 1607.
Well, CPT codes are always a complex issue. So quick question then, do those CPT codes, do they specify what setting they are applicable in, or are they not tied down or confined by that?
It's a great question. What the AMA chose to do is to help us. So I'm telling you, for all of what you hear about physician opposition, the AMA CPT process is an extremely collaborative, collegial setting. And what they did is they said, there's really no reason. And well, here's the other piece. Nor does it define the setting, but it also doesn't define exactly what you do. It doesn't say a diabetes. It doesn't say a hypertension consult. It doesn't say a medication access. When you read that, it's anything that a pharmacist does to improve health outcomes, improve patient safety, or reduce cost, in order to resolve a medication-related problem. Well, I don't love the wording, but it absolutely does describe everything we do. So the perplexing point is we have codes. We got to get more people to use them. We have to get more payers to accept them. That happens when you get more pharmacists submitting and the payers get used to seeing them. And it would be nice if we had a standard rate. So when a code goes through CPT, if it is paid for by Medicare, then it goes through a next train station stop, and that's called the RUC, or the RBRVS Update Committee. So only gets valued, officially valued, if it's a Medicare paid code. Well, we have a dilemma, and many of you may have heard the term provider status. So understand, provider status does not mean that Medicare or anyone else thinks you're not a healthcare provider. By pure logic and definition and training, and we can keep going, we are. The difference is in Medicare, which is a law, there is a paragraph that says who Medicare can pay with federal dollars for a device or product. Well, folks, we're on that one. And that's how we get paid for medications and prescriptions and DME and other and diagnostic devices. There's another paragraph called Medicare Part B eligible provider status. That's the list that defines who Medicare is legally authorized to pay for a provider providing a clinical service to a Medicare beneficiary. We are not on that. So everything about Medicare provider status initiatives over the last few years, which again could be its own session, really is just asking, petitioning, pleading Medicare or the legislators who can impact it to open the Medicare law. It gets opened periodically. It gets edited, amended, surgery performed on it. To open the Medicare law to amend pharmacists to that list. Well, if you think that's impossible, other allied healthcare professionals in the past have accomplished it. And there's two ways to do it. One, the legislators can have a bill that promotes editing that paragraph, or as a result of the healthcare reform legislation, Medicare can itself, if demonstrated with a data set on Medicare beneficiaries, not just something done in Utah, not something done on a health plan in Florida, it's got to be on Medicare beneficiaries. If they can demonstrate that it improves health outcomes, patient safety, and cost savings, they can bring that forward without having to ask the legislature. And I can give you some reasons on why it's been slow and reluctant, and we're getting close each time, but I have faith it's going to happen. But Kevin and Jaron, I want to tell you, I've been in practice since 1991. I am still in business. Have a diverse range of services. The title is, What Are Clinical Services Worth? It's not simply Medicare. So it's commercial payers, it's indigent health plans, it's private payers, it's individual patients willing to pay for the service. I'm just going to do one little pitch, and that is, there is a tremendous amount of healthcare dollar resources expended every year in nutritionals, in supplements, and in other health improvement that is direct out of pocket by patients. Some of the strongest examples I can tell you over the years are patients who found out about our practice and absolutely happy to pay for the service, to know that they have someone, and I commonly refer is that if you think about all the diverse things that we do, even in our practice, what patients share is that we're kind of like air traffic control for a patient's medication profile. And to know that someone is watching, protecting, communicating amongst diverse prescribers, amongst diverse pharmacy product access points and plans is a sense of relief for them and security and comfort for them. And I will totally agree is that I think that's probably a great analogy for what we do. All the rest of the minutiae and clinical services and diagnostics all continue to grow and evolve, but it's helping patients that. So to me, it starts with being able to demonstrate an age-old issue in business, and that is, what is the value proposition to the patient?
Right.
And a willingness to pay.
Yeah.
And I will say that in other healthcare professions, there's been over and over a demonstration that focus on the patient and the private pay first, as they are increasing that volume. And it could be a facility contract. It could be any type of organization that's a payment pathway. As that service is performed and reimbursed through those different pathways, traditional payers and possibly eventually CMS, the single largest payer, you can have an impact. Matter of fact, nursing got to a point strategically several years ago that they said, on your mark, get set, go, everyone submit a claim. And what it did is it barraged payers. Now, you could look at what happened with Kaiser or CVS recently and say, well, let's pick it. Well, to me, this is a healthier version of picketing. If you needed to increase awareness, if you needed to increase a demonstration of the value of what you bring, build that to the point that it's in the payer's face, not withhold patient care. So, everybody's got their view on strategies or methods and that, but I just think that the nursing model and chiropractors and others have been an excellent prototype that we need. And I think we could probably get there this year or next year and start to get at least some very large volumes of pharmacists in different types of practice models to just, there's no problem. There's no rule you're breaking to submit a code, to submit a payment invoice at all. It's the payer's choice whether to pay it or not, but you're not breaking a rule to submit it, with one exception. If you already accept Medicare assignment, So that's a back end agreement that a facility, a hospital, a clinic, a lab, a pharmacy. If you already accept Medicare assignment, then you're not supposed to bill the patient beyond that. Well, the solution for that is have your clinical service team not structured under the pharmacy. It's just basic principle. So Kevin, as you talk about different practice models, it looks like a hurdle, but it's really just a logistic. I'll give you another example. If you look at a hospital or an inpatient setting, where does radiology live? In the basement. Do they have direct patient care responsibilities? No, people are sending patients to them. A service is performed and the patient is sent back. It's a specialty. So we live in the basement as well. We're managing medications. We're providing secondary services. In a radiology model, the radiologist is in a separate practice group that is not the hospital. The radiology department is the hospital. So in those situations, all across the country, the radiology department bills for the film and the support staff that go with providing that. The physicians in the radiology practice model, which is outside the hospital, bills for the clinical interpretation using a CPT code. There's actually a really good reason for that. The hospital can't bill a CPT code. An entity or facility can't bill a clinical service delivery. So it's okay. The hospital contracts and has a radiology group present to help manage the department. If you just stop right there, you've now seen a direct application of what I said in the beginning of the call. Really, all our solutions are already there by physicians: primary care, specialty, multi-specialty groups, inpatient, outpatient. What we didn't have, we had a void, we didn't have codes. We now have codes. I think we're at a point now where we could optimize the development of some new codes, additional codes. In that 2-inch thick binder are a plethora of codes. So the way that CPT community works is it has a group. It looks like a House of Delegates at a national meeting that gets together 3 times a year, reviews all those proposals, and at the center, there's about a 25-person voting panel. And there's a process of how you go from being in this CPT advisor community to get to the panel. So we joined and have been very active as a profession, pharmacy, in the CPT advisor community. And we're very active and go to every meeting and engaged. Well, with that sometimes comes the recognition. And I, about 3 years ago, got voted to sit on the CPT editorial panel, the actual voting panel. Yeah, I don't scare easy, but this one I'm going to tell you is you're sitting in the room of the nation's leading medical billing specialist, to which I say, okay, I'll go in and feel the moment of what's the old phrase? I'm not worthy. Go in and at the same time say, I am now sitting in front of people that can directly impact my understanding and how to carry this information back to help our profession. So we're in a very good place. CPT is in a good place. The pharmacy relationship with AMA and the CPT is in a great place. We're actually very plugged in, and there's a lot of commonality with the other allied health groups, those other non-MDDO groups. It's a very tight community. So I think we're at a point we could begin to expand the codes. There's some people didn't like the 15-minute increment codes. The reality is it does give the greatest initial flexibility for someone to bill. Jaron, we could talk later about the incident 2 codes and how those can be stopgaps or tools to augment the way you deliver or how you're positioned in the setting. And then there's other codes dispersed throughout the CPT code set as well. But the fact that we've now gotten it, and let me just share is that if you look and you say, I thought I heard Dan say a few minutes ago that we're not in the provider status paragraph, which means we didn't go to the second train station. This is all true. We didn't go to the second train station, but they're ready for us because we work with them and know them, and they understand our plight. We just got to get that paragraph edited. So that means we don't have a value on our code. That is not true. We've gone and looked at and sampled across the country, and the value for payers who do pay, pharmacists who do bill for services they are providing, if you translate that back to what a physician is getting using their standard codes to an hourly rate, because remember, we're on 15-minute increments. If you compare those hours, ladies and gentlemen, we're actually doing very well. Even though we weren't formally valued, the value that the commercial market payers do pay, you can't bill CMS. So that's a caveat. What I'm talking about is if you take the codes we have, you have a service that you provide, you document your service, you submit an invoice to non-CMS, which is many payers. So if you could submit that to the patient and they're willing to pay it, why are you not doing it tomorrow morning? Finish this podcast, and why are you not doing it tomorrow morning?
Agreed.
Then billing the commercial payers, many of them do, and they're paying at a decent rate. We just have too few pharmacists stepping into the pool, doing it, billing using standard coding process. I agree. I would love to solve the CMS issue. It is the single largest payer. But back to the point we said earlier, we've got to get people delivering the services, not just talking, not just wanting, but building clinical services, integrating them into their practice settings. It's not practice setting specific. It was a great question, Jared. It's not individual what you're delivering in the service. It's not therapeutic limited focus. There are people over the years in our profession who have wanted to say, I'm trying to think how best to put this. The old adage that, let's just take a little bite, and then next time we'll take a little bigger bite. And so there have been people who said, well, let's just talk about just diabetes. Well, we address and impact so many other areas. Why would you start with that? Well, maybe we should just say only for patients who are in provider access areas, limited access. Well, but we impact people in large communities and cities as well. So why I oppose those types of minimalist incremental starts is because we have other allied healthcare professionals and specialties who are there who did that, and they can't change it. They haven't been successful at changing. So I still stay firm on speaking to the full value, the value statement, the how we impact value-based billing models, where it's no longer just about a fee for service. It's about what happens when you integrate a pharmacist. I'm not speaking to how you integrate a pharmacist as a support staff team member. I'm saying how you integrate a pharmacist at the same concept of a physician partner in a practice. Or take that a step further, build your own practice and you don't have to have a physician in it. So when you hear the word collaborative practice, I deal with collaborative practice every day. My entire profession has been on collaborative practice, but not based on a collaborative practice document. The collaboration and working with other practitioners to affect change for patients. You don't have to have a collaborative practice to do that. If you want a collaborative practice agreement, that's just to afford you a distributed role or responsibility in expanded ordering, starting prescriptions, modifying prescriptions, and in some places, laboratory assessment.
Right.
Outside of that, you can do everything you need to do and you can bill for it, and you don't have to be subjected. Again, a collaborative practice model is a tool for a style of practice, but I really want to caution and make sure that pharmacists realize you can do all this. You don't have to be embedded in one medical practice. I work with physicians across the entire Tampa Bay area, work with hospitals, health plans, long-term care facilities, laboratories. We served as the toxicology director for therapeutic drug monitoring for a major lab here in Florida for many years. And the answer is, well, why didn't they have a pathologist doing it? Because that's not their forte. Who is the highest trained pharmacology expert in the entire healthcare system? That's right. It's pharmacists by far. It's no disrespect to a physician. They get one class in pharmacology in their curriculum all across the country. And by the way, there are many schools who have talked about, out of tight room in a curriculum, to reduce that to maybe like top 100 drugs. If that doesn't scare you, okay. So then behind that, maybe it's a PhD in pharmacology. Well, PhD in pharmacology is typically someone who's done very tight, narrow research in a particular, it might just be one cell type, it might just be one receptor And in fact, when you look at PhD programs in pharmacology, most of them have no clinical training or acumen. So I'd be very hard pressed to argue for somebody to try to argue that an MD or a PhD has more pharmacology and applicable training, clinical practice application than we do. When you look at compare the curriculums, we've done that.
Absolutely.
So with that, that's the kind of thing we have to take back out and be bold enough to say, you can do this as an independent practice. You can do it as an interdisciplinary practice, but you're not restricted to solely say, I want to work in a single doctor's office.
Yeah.
There's
And
a lot of benefit you can bring. But
absolutely. And, I think one good way to explain how a pharmacist can impact is, I think we are by far the most qualified professionals to question prescriptive judgment call. So I had an instance just the other day where a nurse practitioner, we approached them about a Xarelto high dose for a recent clot that's supposed to be 3 weeks, and it had been high dose for 30 days. And when we brought it to their attention, they said, well, that's what the hospital wrote, because they didn't write when to reduce it. So, but we are qualified to ask that question, to question the judgment of that prescriber.
So let me tell you how far that comment has gone. If you look in the CPT code set, there was a concerted effort to allow and provide global applicability. So now when you read a CPT code in its description, it says a physician or other qualified healthcare professional will do the following. And that definition of what is a qualified healthcare professional, or QHP, is a very key thing. And it basically describes all of us non-MDDO. It's someone who is trained, licensed, has a specific skill set. So it's a recognized practitioner, not just someone who says, I do something. You've got to have a skill set and be recognized for it. So the effort was to try to make sure that the CPT code set was as applicable for everybody, except, Jaron, to your point, physicians have gotten accustomed to using a section of the CPT code set that has become almost universal, called E&M, Evaluation and Management. And those are codes that also don't describe diabetes, hypertension, immediate discharge. They're just basically, physician meets with a patient, there's an issue, you figure it out, you come up with a plan, and you move forward. So they're very functional codes. In that process, there is an absolute expectation that if someone is dictating a care plan, dictating a medication course, dictating a surgical procedure or intervention, that they're responsible to check on that and do it right. So I'm going to ask you, when you go to that code set and you go to the back of the medicine section and you find the codes we introduced you to, it says medication therapy management. So there was a lot of people said, well, every physician does that. And they said, no. That's a miss. If everybody did it, we wouldn't have any drug interactions. If everybody did it, we wouldn't have inappropriate prescribing. So what was important in our code set is we're one of the only codes in the whole CPT code set that actually says this is a service provided by a pharmacist. Because to both your points, it was that opportunity to say, like that air traffic control, no, this isn't one person's. This is the person who is in charge of looking at the patient in its totality across all prescribers. And physicians, as a prescriber, should not use these MTM codes as an added code to say, hey, I can use that code on a visit as well and bill for additional. No, it is an absolute distinction between a prescriber and a medication therapy management review by a pharmacist. So I think that's a very subtle but high valued statement that came out of that collegial process.
Man, I think that's really powerful, Dan. And thank you so much for your time this evening. I hope everybody that's listening and that listens and afterwards has their hair tingling just like mine about Dan's kind of fire for the next steps of the profession, and also related to kind of that call to action piece, of Dan really saying, like, why aren't you tomorrow going and doing these things? I think we can have a further conversation. And Jaron and I know we want Dan to come back to really talk about really that mismatching that we oftentimes see, that we have some colleagues in some states say, Kevin, if I do this, I will waste my time, lose money on my staff members, and it won't be a viable business solution for me. And others saying, hey, great, I can make a lot of money doing this and do really well for my community and for my patients. So would love to have you back on that one, Dan. Any closing thoughts, at least for this episode, from you, Dan? We'd love to hear them.
I just think it's develop an appreciation and reach out for guidance. There's many of us can help and are absolutely willing to share time on that. I've got 3 more calls like that before Friday end of day, from 2 in Florida, 1 from out of state. Everybody's happy to share. But where we're transitioning is from fee for service, do a service, build that service, do a service, build that service, into a value-based model. Both are important. Fee for service will never, ever go away, because there's times that you have to do something in an incremental fashion. And in fact, for specialists, which is the model that I think, as the payer thinks of us, is the model that is, we're not there touching or necessarily dealing with that patient in continuum, but could be based on the practice setting. So moving towards a recognition that we'll have value-based, that's important, but an increasing, fee for service, but an increasing amount of value-based, and that's learning how to say, in a collective pie of resources paid to a given entity or across a community, how do you feel confident to say, this is my assessment of the attribution of the outcome of the patient's success and what I think our piece is worth, and how to fight for that and to demonstrate that. And I think that our ability to train colleagues, pharmacist colleagues, on how to demonstrate what that value is an absolutely critical. So I'd love to do updates on any of these and collaborate with you guys on those, but there's just a lot of opportunity today to build. And Kevin, to your point, things that you can do that are not going to be practice killers, and in fact may greatly expand your staff, and you didn't realize that was a potential.
I love that. Appreciate you so much, Danny. Jaron, I'll let you close us out, buddy.
Yeah, it's always a pleasure to chat with you. I could just listen to all your experience and your insight for hours, and it's always valuable and helpful. And you are a standard that our profession needs to get in line and follow. And I appreciate all that you do and all that you've taught me. It's good to have you here. Thank you.
All right. Looking forward to seeing you next week too.
Yeah.
All right, everybody. Thanks for joining us. Any questions, you guys let us know, and join. Hopefully Dan comes back here really soon, but Jaron and I next week on Thursday. Have a great night.
Yeah, we'll see you.